Hello friends, it gives me great pleasure to invite you all to this very unique and innovative online thoracoscopy certification course, which is an initiative of IIB, our Indian Association for Bronchology. As you all know, IIB is a national body of interventional pulmonology, and the IIB-GC would like to facilitate maximum IIB training for one and all, and with this very unique and unprecedented online thoracoscopy certification course, we are bringing thoracoscopy learning to your doorstep. This thoracoscopy certification course will consist of 10 online webinar modules, each focusing on individual important aspects of thoracoscopy in great detail, taught and discussed by the experts in the field. At the end of these 10 modules, we will have 4 physical workshops in 4 different regions of our country, north, south, east, west, with ample of hands-on training and live cases on 4 different dates. And therefore, the participants will have the opportunity to attend the workshop which is closest to them. And for some reason, if they are preoccupied on that day, then they still have the opportunity to attend it in some other place. And this way, we will make sure that every participant gets the opportunity of this abundant hands-on training on thoracoscopy. To get a certificate of completion of this composite and enriching academic activity, participants will have to register and will have to attend at least 8 out of these 10 online modules and any one physical workshop at the end, where they will be conferred the certification of the certificate of completion. The attendance time of each webinar will have to be at least 90% of the total webinar time, and we actually have a system to track this. The highlight of the certification course is that the important thoracoscopy topics, which get discussed only for 15 to 20 minutes in a physical workshop, over here will be discussed for more than 1 hour in each module, and therefore all the information that is required will be given, and thus we are making sure that the learning is complete. With this brief introduction, I would like to invite all of you on behalf of our IIB-GC to this brilliant webinar on rigid thoracoscopy, which is the first module of this very unique, innovative, special, and unprecedented online thoracoscopy certification course. I would like to now invite Dr. Manoj Goyal, our moderator of today's webinar, to please take over the proceedings. As we all know, Dr. Manoj Goyal requires no introduction. He is a brilliant interventional pulmonologist. He is a great academician, a passionate teacher, and also a dear friend of mine. He is the Director of Pulmonology, Critical Care, and Sleep Medicine at Fortis Hospital, Gurugram, Delhi, NCR. Over to you, Manoj. Thanks.
Thank you, Amita, for this nice introduction, and it's a great initiative that has been started by you and IIB. And I can see, there is a great response, and I'm told that there'll be around 1,500 logins today, which is a huge number. So kudos to you, your team, and IIB. And I'm also grateful to Dr. Amita again for giving me this opportunity to moderate this session. And she told me that my role is going to be the most important, but I must admit honestly that my role is going to be very much limited, because I got excellent panel, highly acclaimed, interventional pulmonologists who are renowned all over the country and highly experienced. So my job would be just to facilitate the discussion. So coming to the topic today, we'll be talking about the basics of rigid thoracoscopy. We know the thoracoscopy, or what we call as a medical thoracoscopy, which is done by the pulmonary physicians, also called pleuroscopy, is done under local anesthesia. And our aim is basically a diagnostic procedure where we want to target mainly the lesions on the parietal pleura and take the biopsy on there and do a little bit of therapeutic work. It is unlike the surgical thoracoscopy, which is called as VATS, or video-assisted thoracoscopic surgery, which is within the domain of the surgeons, who do all kinds of therapeutic work, exotic work, and our job is actually very much limited, as I said, is mainly a diagnostic one. So today is going to be the first module where we'll be talking about the basics of the rigid thoracoscopy, and if we identify the expertise, the levels of thoracoscopy, there are 3 levels of thoracoscopy: level 1, level 2, and level 3. So in level 1 thoracoscopy, the operator is able to do thoracoscopy in patients with large pleural effusion, can do biopsy from the parietal pleura and do talc pleuridage. We won't be talking about level 2 thoracoscopy, where the operator is much more experienced. He can do thoracoscopy in patients with small pleural effusion, in fact with no pleural effusion, and can take biopsies from the visceral pleura, also can do some sort of therapeutic like adhesionolysis, where he would break the various septations to make a large cavity for adequate drainage, and can also do talc pleuridage in pneumothorax in patients who cannot undergo VATS because of some reason. And some of the medical thoracoscopists can also perform procedures like sympathectomy, the thoracoscopy sympathectomy. And the level 3 thoracoscopy is again not in our domain, because this is just a surgical procedure, what we call as VATS, and within the domains of the surgeons. So we would be basically focusing on the basics of rigid thoracoscopy and level 1 thoracoscopy. And for this, we have an excellent panel, as I said. And without much of ado, I would request my panelists, who actually don't need any introduction, and they're known to each and everyone in India. So I would request my panelists to first, introduce themselves and tell us something about themselves. So I would invite Dr. Nitin Abhyankar to kindly introduce himself. Hi, Dr. Nitin.
Hi, Manoj.
Yeah.
I'm Dr. Nitin Abhyankar. I am from Pune. I work in Pune Hospital and Research Center, and I've been actively involved in medical thoracoscopy practically since 1996 and effectively since 2000. So at least 24 years I can count. So I think that is the kind of amount I have invested into this. It's my passion, and I think we are one of the only units who is doing thoracoscopic lung biopsy. But well, we are not going to discuss that today at all, because we are at the my talk is going to be on the nuts and bolts, which is very, very basic. So no exotic stuff. Absolutely.
Yeah, but
Welcome
having
to
said
this
that,
wonderful idea of having this seminar, and I'm very glad to be invited as I'm one of the opening batsmen here.
thank you. And everybody knows that you do a lot of exotic work in medical thoracoscopy, perhaps the most experienced person in the country. Dr. Abhyankar can do, thoracoscopy in the patient who do not have any effusion or any pleural fluid. He can do take pinch biopsy of the visceral pleura and take thoracoscopic lung biopsy in interstitial lung disease. So there's a lot of experience behind him. So welcome, Dr. Nitin Abhyankar.
Thank you.
Our next speaker is Dr. Arjun Srinivasan. Hi, Arjun. Are you there?
Good evening, sir.
Good evening.
Sir. Good evening.
Please tell us something about you.
I am Dr. Arjun Srinivasan. I'm from Coimbatore. I'm part of a team of 3 of us, and we've been doing medical thoracoscopy for the past 15 odd years. And my area of interest is thoracoscopy in empyema, and that is what we've been doing for a while. And of course, today, like Dr. Nitin said, that it's going to be how to get into the basics of rigid thoracoscopy, which is probably, with the advent of rigid thoracoscopy, sort of a dying art and that's what we look at. Yeah.
So Dr. Arjun, many of you would be know that he is a super athlete as well, apart from being an excellent and one of the best interventional pulmonologists in the country. So if you're a fitness freak, then you can always contact him for any fitness tips. So welcome, Dr. Arjun. Very nice to have you on board.
Thank you, sir.
And then we have Dr. Swami Pawar from Mumbai. Dr. Swami, hi. Are you there?
Hello.
Yes.
Good evening.
Please switch on your video, please. Yeah. Hi, Dr. Swami. Yes.
Yeah. Hello. I'm Dr. Swami Pawar. I'm from Mumbai. I'm doing thoracoscopy for last 12 years. And it is great to be part of this panel, especially when your teachers, like my inspiration has been Dr. Nitin sir only, that he has inspired us to do the thoracoscopy and interventional work. So last 12 years, we are doing the thoracoscopy. Yes.
So Dr. Swami is again a very well-known figure in the country, and he is one of the key figures in organizing BronchoCon 2023 in Mumbai, the Silver Jubilee BronchoCon. So welcome, Dr. Swami. It's nice to have you on board.
Thank you.
Then we have Dr. Pratibha Gogia. Hi, Dr. Pratibha. Are you there? Dr. Pratibha?
Yes.
Dr. Pratibha? Dr. Pratibha Gogia,
Yeah, she's
I
on.
think she is about to join us. Then we have our great friend, Dr. Shyam Krishnan from Kolkata. Hi, Dr. Shyam. Are you there?
Sir, I think he's on mute, sir. I mean, sir, I'll try and.
Pratibha is visible, so you can talk to her.
Pratibha, are you there?
Sorry. Yeah.
Can't see you.
Can you see me now?
Yes,
Yeah,
yes. Now we can see you. Absolutely. Yeah.
Good
Great.
evening, sir.
Yes. Please introduce yourself. We know all you all, but yeah, please. Just for
I'm-
formality.
Gogia. I'm an IP enthusiast and doing medical thoracoscopy, rigid, especially since means it's almost more than 13 years I'm doing it. And I agree with Arjun that probably rigid thoracoscopy is a dying art, but I believe that it is one of my most favorite procedures because it is very fruitful most of the times. Whenever we select to do a rigid thoracoscopy, it always gives results.
Thank you, Dr. Pratibha. So Dr. Pratibha recently delivered at Oration in BronchoCon 2023, which was highly appreciated. And
Yes.
she's an excellent pulmonologist, a very renowned international pulmonologist, known all over India. And our last panelist, but not the least, Dr. Shyam Krishna. Dr. Shyam, are you there? Dr. Shyam?
I think he is not yet
Sir, I
visible.
think he has a connectivity issue, so we can start.
All right. So without much ado, I would invite Dr. Nitin Abhankar to please deliver his talk on rigid thoracoscopy, nuts and bolts.
Yeah.
Dr. Nitin, please.
Thank you, Dr. Manoj, and I am going to introduce the basic. I mean, this is opening batsman, but well, I mean, there's a huge laundry list of phenomenal speakers over the next 10 weeks or so, and then so I think I'll be forgotten by the end of this whole thing. So I think, though it's an opening batsman honor, but at the same time, I still consider it as honor. I'm going to take you through the nuts and bolts of this. And if the tech team is ready, my video is already loaded. So please start it. And I'll take you through this. Good evening. Welcome to this wonderful initiative and a very, very long workshop. A workshop with a difference where the theory will be covered in advance. Excellent initiative by Indian Association of Bronchology. And I'm Dr. Nitin Abhankar, and I'm going to talk to you about the rigid thoracoscopy, the nuts and bolts, the very basics of it, and Arjun will take it into the next level. The studies that I'm showing you range from, say, 1977, where Canto used thoracoscopy in the diagnosis of pleural effusion. And then the story goes on. 14 studies on malignant pleural effusions, one after the other, and so on and so forth. So this story has been going on for good 45, 50 years. And there is a huge scope for it to expand. In a country like India, it becomes even more relevant from the diagnostic point of view. When you want to do a medical thoracoscopy, you are essentially trying to create a port, a safe port, which goes into the interspaces. And there's a myriad of range of trocars which are available to create the port. So you could be using a sharp trocar, you could be using a blunt trocar, a plastic or a polycarbonate kind of things and things like that. And you could be using blunt versus optical. So there are all kinds of trocars possible to insert. But the most important and non-forgettable thing is whenever we are trying to insert the trocar, it should go above the lower rib, because below the upper rib is your intercostal artery, and breaking that can create a catastrophe. So when you are dealing with creating with the port above the lower rib is your first take home in this whole process. Most instruments which are used for medical thoracoscopy contain a light source. The light source gets connected here. There is a working channel, and you can appreciate there is a biopsy forceps which is coming out of this working channel. And then there is, of course, some kind of a video port. And All these are in a single device and therefore allowing a single port. So most of the medical thoracoscopies are done using a single port technique. Some thoracoscopes are 0 degree, some are 30 degree, and there could be a 50 and a 90-degree telescope also possible. This will create a bigger panoramic view of the pleural cavity, but sometimes this can be confusing for a person who is not so intelligent like me. 0 degree works the best. So I think you can stay with 0 degree, but it's your choice. You have to get used to the idea how you are looking at the cavity, and that is important. Say, who does qualify to become a medical thoracoscopist? It would be a chest physician, an interventional pulmonologist, a thoracoscopic surgeon, or thoracic surgeon. Obviously, he has to be experienced in an intercostal training session, so he knows exactly where the interspaces are, and preferably somebody who sees things, so he is preferably a bronchoscopist. How does he maintain competence? The 15 procedures he does, first procedures are done under supervision by a trainee. And then in order to maintain the competence, we have to do at least 10 procedures a year. That means at least about a procedure a month. In a busy setup like ours, we do around 10 to 12 procedures in a month, but one procedure in a month can be enough to maintain competence. It can be only performed. The bottom line is, it could be an IP guy, it could be a physician, it could be a thoracic surgeon, but the person must be properly trained into it, one way or the other. Could be done anywhere. Very frankly, we can do it in a minor or a major operation theater and an endoscopy suite. And if you look at the Western data, they say it is generally performed in an endoscopy suite, less commonly into the operating room. But whenever you're dealing with something a little more complex, it is better performed under GA than go to the operating room. And the most important bottom line is fluoroscopy must be performed using standard surgical sterile technique, drapes, gowns, gloves, the whole works. Bronchoscopists or physicians typically are used to wearing just a mask and gloves, and they consider it good enough. This is not good enough when you are doing a fluoroscopy. You have to be completely sterile, like a surgeon. Fluoroscopy or medical thoracoscopy are the two words which are used practically interchangeably. And initially, when Rodenkamper described it, this was described as an endoscopic examination of a chest cavity with an induced pneumothorax. I think the concept of induced pneumothorax is more or less out. We will touch upon that later towards the end. What do you require when you want to do this, the nuts and bolts of it? We started doing it only on a pulse oximeter, but most of the times, usually our anesthesiologists are well equipped with a multi-parameter monitor, which includes saturation, which includes EKG, it includes non-invasive blood pressure monitoring, and it also gets RR and some other parameters. You may or may not use an anesthetist, but trained assistant nurse is absolutely essential. You will need various sizes of trocar. We have 5 and 10 trocar cannula for port creation. Appropriate sized, we prefer 0 degree telescope. It is your choice, 30, 50. That will be your training and choice. A good light source, a biopsy forceps, either an optical one as I have shown here, or an ordinary one, that is good enough. Suction accessories, and preferably add a cryo also, use a cautery also to that list. So please add cautery, just in case you get bleeding, you can get a better control. Is it a must to use anesthetist? And we have various resource settings. So in a resource limited situation, when you are doing a pure diagnostic fluoroscopy and you are limiting yourself to using just say midazolam and fentanyl, you can do away without an anesthetist if you are trained yourself in using appropriate doses of this. But if you are doing more extensive work like adducial assays, therapeutic applications, even for talc, which is a painful process sometimes, then an anesthetist becomes mandatory because you are going to use drugs like propofol, ketamine, and isoflurane, which will need extensive monitoring also. So I think one has to do that. And if you're using a G, obviously anesthetist is needed. A typical trolley for a medical thoracoscopy looks very, very similar to a intercostal drain insertion trolley. Add to that a trocar and a cannula. This is actually an example of a short trocar, so you won't be using that anymore. And this is your thoracoscope, and that's the biopsy forceps that's there in the background. So I think that is your telescope basically, and the light source and so on. Those are the additional things. The rest everything looks identical to an ICD intercostal drain insertion trolley. Point of entry decision is the critical or $1 million decision, and in most of the situations you'll have to deal with this all the time. And the patient is typically placed in a lateral position with the affected side up. Look at the amount of drapes and the covers that my sister is putting on this particular patient. I think that is another important message I will re-emphasize. If it is a largish effusion and in a busy center, what we do is we just get it marked, and we mark the diaphragm, making sure that we are never going to go above the diaphragm, below the diaphragm. And this particular mark is very useful for you to start the process. And then once you aspirate fluid, it is reasonably safe to go in. So it doesn't create much of a problem. Of course, proper history, prior imaging, CT scan. Now this is a multiloculated effusion. So you have to know where it is, and then accordingly the port will get decided. But I mean, these will add, but they will not replace ultrasound. Ultrasound is more or less mandatory to be at least used prior to the procedure, preferably on site. How this practice of say inducing pneumothorax I was talking about is more or less gone, because you have an ultrasound which can not only pick up loculations beautifully, but also pick up things like empyema and separate the lung out. So make sure that you are going into a right site, and that will be very, very important. A bedside ultrasonography is the best idea to have, because it selects the entry port in a proper way. It optimizes the chance of success by avoiding the adhesions and may reduce trocar access failures, pneumothorax rates, and even the lung injury. So I think, and these are the references for that particular entity. So very important. This is an example of a Butein's needle. I've used it once in 35 years, but I don't think we really need to do that. Basically, there are other ways of bypassing it now. But in the past, when pneumothorax was induced prior to sedation and there was no CT scans there, so they used to do a chest radiograph before thoracoscopy is done by inducing a pneumothorax, allowing the air to go in, take the chest X-ray, and then decide which is the best interspace to go in. So that's the Butein needle, just for the remembrance. When you look at the cost, why am I really as a physician interested in this? Is I'm saving a lot of money for my patients for a diagnostic procedure, because the average cost of medical thoracoscopy in my institute is just around 50,000, and an average cost of VATS is in excess of 250,000, so around 5 times. And therefore, for a diagnostic purpose, I would not subject most of my patients to a surgical or a VAT surgery. It doesn't make logical sense. So I think this is a skill which is worth acquiring. Of course, you have to know your limitations and stop short of getting into an zone of too much adventure. When you do it, most likely you are going to do it for an undiagnosed pleural effusion, and once in a while for a talcophoresis. So these are the two main indications. The most important thing, once again, as I told you, while re-emphasize this 20 times, that completely sterile techniques. You'll have to give local anesthetic, create a incision, and then do a blunt dissection using an blunt artery forceps. And you have already marked the position entry point. And once you are in, then you are on your way to looking into it after emptying the fluid. So the next step, of course, is going to be putting a trocar in. And once you have put a trocar in, then this is one more video which will take the same. And while giving the local, you can also go into the deeper muscles and feel GAD. Then there's a giveaway, so you are almost touching the pleural cavity. So you will know exactly where it is done. Now this one was done in a nearly conscious patient, conscious sedation, and this was done by us, so there was no anesthesia at that point in time. So the patient is very mobile, as you would not like it today. And this was done about 15 years ago. And well, I think once again, what you're doing is dissecting the the muscles and the fascia are layer by layer, and then creating once you again, then yeah, here is the point where you begin and you are dilating, and then it becomes reasonably safe. And then after emptying the fluid out, you start looking at the pleura in various ways, and these are the examples of what you can look at. So down here, this is a tubercular effusion with typical tubercular adhesions with it. This is a fibrous mesothelioma. This is a metastatic malignancy. And you can appreciate the kind of metastatic nodules which are there. And this is another example of metastatic nodules. So the pleura, which is parietal pleura, which is invaded by this metastatic nodule. So I think that's going to be the way you go forward. And of course, I mean, there were days when we were bending our backs like this, but now with the video connector getting connected here and having a very good video screen, the visualization is much simpler. Here is an example of one more metastatic nodule, if you like. This is an example of a patient who was referred for a drug-resistant tuberculosis versus a malignancy, and it looks like both, but it actually just turned out to be a slow responder. And this is another metastatic nodule which you can look at. So that's how the whole world opens to you. In fact, what meets the eye is not necessarily the same. And this is again, I'm showing you the example that there are 2 or 3 things worth noticing. The lung continuously keeps moving. So you will have to stay away from the lung, go towards the parietal pleura. So you position yourself in that decay. And then when you are taking a biopsy, the biopsy is taken from that particular area where you are going to be safely away from the the lung, and you are taking this up. The pinch and peel and the other things will be discussed eventually. And you also can notice that there is a little bit of fluid still there. So I think these are some points worth keeping in mind. Before I wind up, few take homes. One very simple thing, very simple to understand, is if I have a large non-dependent part of the pleural collection is in the non-dependent area like this instead of dependent area here, then this is a loculated effusion, and be ready to encounter huge number of lesions. That's going to be important. That depth of parietal pleural thickening, today the CT contrast is so good that it gives you a very good idea. So how deep are you going to go in with the trocar? How deep do you have to go will be decided. But previously we used to use the needle feel and the blunt dissection artery feel. So many fields are available to you to decide exactly how much you should be going. And with an ultrasound, it has become much safer. There is no doubt about it. This is the last slide, and I'm just showing you a varied range of tubercular pleuritis. This is just to increase your appetite for thoracoscopy. This is something which just a biopsy forceps with a rigid fluoroscopy can take care of it. This is just a tip of a rigid fluoroscope can get rid of all these adhesions, and you won't be needing any dissection at all. But adhesions like this, the last one which I'm showing you, may not be all that amenable to easy removal, and you may need to call a thoracic surgeon to do that part. And particularly if the visceral pleural rind is very thick, then there is no point in venturing into that. The thoracic surgeon takes over in that at that point in time. So this is just the beginning into a new space, and that is your pleural space. It's worth visiting whenever indicated. You should know your limitations, and welcome to this new journey. And from here onwards, Arjun will take over. Thank you very much.
Thank you, Dr. Nitin, for such an exhaustive, simple, and practical, display of rigid thoracoscopy. And you could clearly show the nuts and bolts while doing the rigid thoracoscopy and identify the right kind of patients and, the precautions. All the major aspects actually have been covered by you in a very simple way. So now I would request Dr. Arjun to please deliver his talk on rigid thoracoscopy, how he would do it. Dr. Arjun, please.
My slides visible.
Yes, yes. Please go
Yes.
ahead.
After that excellent introduction by Dr. Nitin, where he has actually given us an overview of how things are going to pan out over the next 10 modules, we will look at how a rigid thoracoscopy is done. And you have seen excellent videos projected by Dr. Nitin. And this actually comes after years of experience, because rigid thoracoscopy per se, as against we were discussing in the beginning, it's a dying art, because the learning curve is a lot steeper with rigid thoracoscope, because it is not as intuitive as the flexor rigid thoracoscope. As bronchoscope is, flexor rigid thoracoscope is just extension of what you do in a bronchoscope. It's basically a smaller bronchoscope. So you're already very comfortable with what the thoracoscope shows, as against the rigid thoracoscope, which is basically something completely new that we need to learn. So when we look at this, the agenda here is not to try and see how rigid is different, and how do we deal with issues that are specific to rigid. And when we talk about rigid, it's not a single rigid. There are multiple type of rigid thoracoscopes which are available, and each one has their pros and cons. And once you're inside, first orienting yourself inside the thorax, and a short video of how you would go about doing it, with trying to give some practical points as to how things can be made easy for you when you venture into the pleura with a rigid thoracoscope. So moving on, so how rigid thoracoscope is different is like, this is all you have in terms of rigid thoracoscope. So all you have is a rigid tube, and like Dr. Nitin showed, this is where all your instruments go in, and this is the extension wherein your camera comes in. So this doesn't bend. So when the thoracoscope doesn't bend, it means that you have to be flexible. So the flexible part in a rigid thoracoscope is actually the operator. And when you take a cross section of this, this is similar to, there are three things that you would see. There would be an instrument channel through which your forceps goes in, your suction catheter goes in. There'll be a light source, and there'll be a camera, which is a camera attachment, which is the optical attachment. And and the camera per se gets attached on top here. So this is one place where it is vitally different, in the sense that it is a loose sort of attachment between the rigid thoracoscope and the camera, as against the flexible scope, wherein the whole thing is a single package. So it means that this camera is free to rotate. And this is very important when you're inside the thoracic cavity, especially when you're starting off. So this is a short video we're trying to look at. See, there is an arrow. We're trying to orient ourselves with the arrow. But once you have the thoracoscope and the camera in place, a minimal movement of your wrist will disorient the arrow which is there. So the arrow is supposed to be pointing up. If there is a minimal movement of your wrist, this will disorient what you're looking at, which means to say that you need to have a very stable wrist when you're working inside the pleural cavity. So this is another thing. So since the camera is a loose attachment on top of that, this camera can rotate, and sometimes it happens because you're so focused on what is happening inside the thoracic cavity that it might rotate, because there is a push and pull that happens. And when that happens, again, you get disoriented inside the thoracic cavity. And this is something which is very important when you're starting off. So this is, again, if you look at it, this is a thoracoscope which is there already inside. And when we focus, we look at the wrist. So this wrist has to be held in place, and this camera which is orienting. So this is what is showing the where the operator is standing to the front of the patient, and you're seeing the posterior wall. When you're seeing the posterior wall, unless and until the camera is facing up, like that's how it has been calibrated, and your wrist is in position, it will, you can get easily disoriented inside. So this is a focus on the camera, how it is. And if you want to, so this is where you're looking at the posterior of the pleural cavity. Supposing if you want to actually look at the apex, which is where here, you need to actually use this as a fulcrum and take your hand down without any change in the rotation of your wrist. And if you want to see what is happening at the base, you will have to actually take your hand up. So this is the type of movement that is required once you are using a rigid thoracoscope. So another thing is the rigid does not have suction on the fly. If you look at the, flexi rigid thoracoscope is similar to what you have in a bronchoscope, which means that you have a suction button. So whenever you don't see whenever there is a fogging that happens, all you do is briefly touch on the suction button and usually the view clears up. But since it does not have a suction on the fly, the vision tends to fog a lot more, especially when you're starting off. So this can be tackled by attaching suction to the auxiliary adapter which is there, or using a suction catheter. But whenever you use a suction catheter, there is always a risk. So you can see that this is the underlying lung. You're looking at the posterior wall again, actually. So when you're coming inside, you can see that there is a little bit of fogging that is happening. And as soon as you switch the suction on, it has to be very low and it has to be properly regulated. If that does not happen, what will happen is the suction, because it is a closed pleural space and it's a tight fit, the trocar that goes in, the suction will lead to the pulling up of the lung, which is the most pliable structure inside the pleural cavity, and your view will get obscured. So this is something that again happens when you start off doing thoracoscopy. So again, like we said, this is what happens. So this is the underlying collapsed lung, and this is the trocar or the thoracoscope that you see. So if you see that, depending upon the depth at which the thoracoscope is there inside, that also affects your field of vision. So if you push the thoracoscope too far in, this will lead to, you'll be too close to the trees to actually see the forest. And so you can see that there is a significant difference by a few centimeters of depth. There is a significant difference in the field of vision that you see. And you can see the apex and the base, like I've already said, by tilting the thoracoscope to one side or the other. And if you see that, if you actually take all the orientation together, you can see that a significant part of, without the distal part of the thoracoscope bending, you can cover a significant part of the thoracic cavity without getting missed, without things getting missed. So again, when this trocar is advanced further, the field of vision can be increased further to look at the apex also. So we talked about different rigids. So at least there are 3 different rigids which are there. So one is the classical rigid, which Dr. Nitin has shown, and this has an outer diameter of approximately 10 mm. And this has a very, very large sort of channel. So what happens is, as you use larger and larger, thoracoscope, it will have a larger, channel through which instruments can go in. But what happens is, you have limited space between the ribs. If you take this as the space between the ribs, you have limited space between the ribs. So when we go back to the previous slide, if you have to actually manipulate this thing to see what is going on inside, the amount of manipulation will come down with as the size of the rigid thoracoscope gets larger. And when the rigid thoracoscope gets smaller, you will be able to easily see a better field of view because you are able to manipulate it better. And also this is more, it is more favorable or more tolerable to the patient because you are not be impinging on the underlying rib. But now, again, with the smaller thoracoscope, the optics usually aren't as good as the larger thoracoscope. So now we'll get into part of actually how you do it. First is, as you enter, first is to how do you orient yourself. So this is the right side, the pleura we are seeing. The lung is nice and collapsed. You're on this, the operator is at the anterior end of the patient, and you're looking at the posterior end. What you are seeing, this is a very thin patient. You can see the ribs very clearly. These are the upper end of the ribs. So this is at the base of the patient. This is the apex of the patient. So you can see the ribs are very clear, and you can see the neurovascular bundle which is running below the ribs. So this is the posterior where you're able to see the neurovascular bundle and on this. So when you move towards the apex, so this is the apex of the patient. So you can see that By sweeping towards the apex, you're able to see the apex. And when you move down, you can clearly see that this is the diaphragm, this is the posterior chest wall, and this is the lower lobe of the right side of the chest. And when you move further, you are actually able to see. So this is the major fissure that you're seeing. This is the minor fissure. This is the upper lobe, which is this is the anterior chest wall. This is the upper lobe. This is the lower lobe, and this is the middle lobe, which is towards the anterior and the lower part. So this is something that you can easily. It is usually difficult to identify these things when you are doing it for a pleural effusion, but when you are doing it for a patient with a pneumothorax, usually these are very easy to identify. Again, on the left side, you're again seeing the neurovascular bundle, the upper border of the rib. And when you go towards the thing, this you're seeing the apex of the left side. You're also able to see the subclavian artery at times. Now, it depends on how much the lung is collapsed. So that is what will dictate how much you're able to see. So this is the orientation that you should be able to, again, you're able to see the diaphragm here down. And this is the posterior chest wall, lung, and the diaphragm. So this is where you are, and you're able to see the fissure also. So now, Dr. Nitin told us about the conventional area of entry. The conventional area of entry is taught as the patient in lateral decubitus position, mid-axillary line, which is in the 4th or the 5th intercostal space. And these are the anatomical margins that you can see from any textbook. So again, Dr. We have to make sure that you do a pre-procedure ultrasound, which has to be ideally, so this is a patient which is having a little bit of loculation. You can see that there are places where the lung is actually adhered to the chest wall, and there are places where you have a free flowing. So you want to make sure that you try and avoid the areas wherein the lung is adhered to the chest wall. So now we have to look at the analgesia. So diagnostic thoracoscopy can be done under local anesthesia with conscious sedation. Liberal infiltration. So this is the most important thing, and we will look at it when we are actually doing the procedure. Infiltration of the subcutaneous plane, periosteum of the corresponding rib, parietal pleura at the site of entry helps in reducing pain to a great deal. And if you spend a few minutes doing this thing, the patient will be very comfortable, and you'll be able to complete the procedure fast, and you'll be able to do a proper procedure. It's not that you take a couple of bites and you get out of the thoracic cavity. You'll be able to get adequate time inside. And of course, a lot of these patients are quite apprehensive, and the fentanyl or midazolam can be used, which we usually fare a shade better than propofol for sedation. Intercostal block. So this is something that you can, even if you do not have an anesthetist when you're doing the procedure, this is something that you can talk to your anesthetist. So a lot of times these anesthetists, you can talk to the anesthetist as to how you can give intercostal block. So these are blocks that can be given in the form of either erector spinae blocks or depending upon whatever regional anesthetist is comfortable with, and this can greatly reduce the need for post-procedure analgesia also. The patient is very comfortable. So like Dr. Nitin said, that if you're going to be doing anything more than a diagnostic thing, then we'll need anesthesia, and this is way beyond the current thing. So again, we talked about erector spinae block, multiple intercostal blocks. So it can be done in the intrathoracic. So when you're completing the procedure, like we showed the rib and the neurovascular bundle, you can go along the neurovascular bundle and you can give multiple intercostal blocks, and that can help reduce the post-procedure pain. And the patient is able to take deep enough breaths, and your chest tubes can come out fast. Some of the centers also use paravertebral blocks. So these can be a useful adjunct, especially when you're starting off, to try and have a very calm patient so that you're able to complete the procedures. So this, over the next 5-6 minutes, we'll be looking at actually doing the procedure. So this is another thing. So we're trying to go into detail as to how you do the procedure. Like we are trying to do on the right lateral, and the patient is on the left lateral position. You have to make sure that the hand is nicely abducted away, so that there is a rotation of the scapula, and this opens up the rig space. So there is one more way that you can do, is that you mark the underside of the scapula, and then you try and palpate for the anterior part of latissimus dorsi. And when you mark this thing, the place where these two intersect, so this is usually the position of major fissure. So this is very important because you can do this in a patient who's having a free flowing effusion also, and then use an ultrasound on set to make sure there is adequate effusion. So a lot of times what happens is, when though it looks like a large enough effusion when you start off, when the patient is on the opposite side, when patient is on the opposite side lateral position, you find that all the fluid has actually gone off to the paraspinal area. And you can see that here the lung is sliding well, which means that the lung is not adhered there. So that is most important also, that for you to decide on the port position. So this way of marking is very good in terms that this gives you a very good, if you're going to be using only port like you would be using with a diagnostic thoracoscopy, this gives you a single port that can give you a very good access of the apex, the lower part, and the anterior and the posterior. So you can see the draping process, like Dr. Nitin mentioned, it is going to be like you are doing a surgical procedure. The entire patient gets draped, the entire chest wall gets prepared, and you have to make sure that because what happens is when you are using the camera, you have to make sure that every part, including the the camera, the suction, everything that is there is on the sterile part and nothing is touching the non-sterile area. You can see that how the suction is being secured to the sterile area, so that this is another thing which you would commonly, because we are not used to such procedures, that suction may fall off when you're busy trying to do the procedure. So again, skin and the subcutaneous tissue, you can see that the skin is being infiltrated, and once you infiltrate the skin, you go down and the subcutaneous tissue is being infiltrated. So what you can do is 1% or 2% lignocaine, both of them are good enough. So you can actually increase it to 1%, dilute it to 1%, that will give you a larger volume. So you go and palpate the rib and then give it over the periosteum, because this is the point at which your trocar is going to be hinging, and it is a good idea to actually give it to the periosteum. And then you go and aspirate a little bit of fluid, come back, and then try and infiltrate into the parietal pleura also. This is very good because parietal pleura, as you all know, is very pain sensitive. And once you infiltrate the parietal pleura, this will reduce the pain at the entry site. So now, once you have marked the site, and whether you're doing a rigid thoracoscopy or flexi rigid thoracoscopy, you do not need a large incision. The incision, most time you will be about 1 centimeter incision, and you need to have your assistant try and keep the field clear. So now notice how the dissection is being done. You would use the curved artery so that the curved artery is arching over the rib. And when you're dissecting, you will go closed inside, open, and then come out. So this is to make sure that you don't catch any intercostal, aberrant intercostal vessel which is there if you actually close and come out. So you go in closed, open, and come out. So this will make sure that you are able to. One of the things Dr. Nitin said, and the other thing that you can also use is you can use the finger to judge the depth. Once you use the tip of the finger is very sensitive, and you'll be able to feel whether you are in the intercostal area, whether you have actually gone through the muscle, and all these things can be easy. So you can see that using the finger we have judged, and the trocar is actually gone inside. So now the trocar is inside. So now we will skip through, because first thing will be a flexi rigid. So that is not for today. And we look at a rigid thoracoscopic biopsy. Now, if you look at it again, you see the position. The position has to be fixed. So this cannot rotate. Your hand has to be in the same position only. So this is the forceps that is going. So this is a rigid thoracoscope with a channel for the forceps to go inside. And you can see that there are some thin, very flimsy adhesions. So you need to make sure that you have a clear area to see. And you can see that the vision is not as good and it keeps fogging. So this is to initially try and take off something. And again, one of the things that you can do is, instead of trying and pulling this thing into the channel each time, you can come out en bloc. So this will reduce the number of times the forceps goes into the channel, as well as reduce the duration of the procedure. So you can see that the whole thing is being caught. The forceps is not being taken into the channel. A lot of times you'll be picking up tissue which is a lot more than what can enter the channel. So now you have a clear access to the chest wall. You will have to confirm that the forceps is over the rib. So you can see that now we are sort of scraping to make sure that the forceps is over the rib. You pinch and then peel away. So if you just pinch and come back, what happens when you do a biopsy is that no, you will not get a large enough tissue. And once you take an initial bite, you can sort of target the edge of the parietal pleura, again pinch and peel away. You can see that nice large chunks of tissues coming out, and this is more than sufficient. So whenever you do a biopsy, always take adequate things in both formalin as well as saline, so that you are able to send for cultures also. So this is what it is. Now you can see that the entire parietal pleura is looking abnormal. So once you have taken adequate biopsies, now the same trocar, whether you use a rigid trocar, if you're using a smaller, a mini rigid thoracoscopy, even a flexi-rigid trocar would do. Same trocar can be used to place the chest tube inside, and you would probably place it around 8 to 10 centimeters. It will be used, and then the trocar can be gotten out. So you can see that the trocar is gotten out at the same setting, and the chest tube is sort of secured in place. So once you have the chest tube inside, then it is just like securing any chest tube. You're going to be doing what is called as, you will not be taking a purse string suture. You'll be doing what is called as a braided suture. The braided suture sort of helps in not, there is a less chance of the chest tube slipping out, and it will be connected to underwater seal, and the patient can then be, the procedure can then be completed. So you can see that the chest tube is being placed. So usually the largest, the flexi-rigid thoracoscopy trocar would take chest tube would be 24. And we generally tend to place a 24 trocar whenever you're using a flexi-rigid trocar, and the larger trocar if you're using a rigid trocar. Then with the larger Karl Storz rigid thoracoscope, then a 28 chest tube is usually placed, and you can see that the initially you are securing, you are making a tie, and then this chest tube will be, you sort of take a braid around the chest drain, and it will be secured in place. So when would you prefer to do? And of course, when this is the only one which is available, so you do not have a choice. When you are expecting a complicated sort of effusion, in the sense that it is like Dr. Nitin showed, it is a much better tool, much faster tool to actually get the procedure done. When you want to do more, when you want to do a little bit of, when you want to do pleurodesis, when you want to do adhesiolysis, and when you anticipate difficulty in taking biopsying a lesion. So especially this is true in flat top lesions. You can see that this is a very flat top plaque-like lesion, and these lesions are at times very, very difficult to biopsy when using a flexi-rigid. And you need to be taking much deeper biopsies in them, and then in the pretest. So this is, though it is not very common in Indian setting, but if you have a pretest of mesothelioma where you need to take deeper biopsies, probably rigid thoracoscope fares better. So how long do you keep the train in once you're done with the thoracoscopy? It depends on the indication of the procedure. So if you're going to be taken now a diagnostic thing and whether you are able to document the expansion of the lung. So in uncomplicated diagnostic procedures, we often take the tube out in 4 to 6 hours post-procedure, and a lot of time the patient gets discharged on the same day. But if you're doing a therapeutic procedure, like if you've done a tal fluorodesis, or you've done an adhesiolysis, then at times then you might have to keep for 2 to 4 days or longer. Post-procedure complication, when you are doing for a diagnostic indication, where you have gone through the pre-test checklist, and you make sure that the patient is not having coagulopathy, is not on antiplatelets, not on anticoagulation, does not have a lot of comorbidities, then it is a very, very safe procedure. And the most common thing that you would, the patient complaint would be minimal post-operative pain, and this can also be reduced by reducing the amount of time the chest tube is inside, and that is what we've been doing for the last 4 or 5 years. We are taking the tube out, in the next 4 to 6 hours time, and that brings down the pain significantly. And also doing either erector spinal block or intercostal block or a paravertebral block, if you're able to do it, that also reduces the post-operative pain. Bleeding from the incision site, again, if you're doing a very large incision, if you're doing a very large incision and you're trying to close it very close, very tight to the chest wall, then it means that there'll be a lot of, you're only closing at the level of cutaneous level. So the subcutaneous area and the parietal pleural incision is quite large. And when these patients sort of coughs, then it can lead to a subcutaneous emphysema, and there can be a little bit of ooze from the incision site also. Major complications are rare if you are not venturing into therapeutic and if you are careful in selecting your patients. But very, very rarely you lung laceration, major bleeds, bronchopleural fistula, and the most dreaded of all these things would be a post-procedure empyema, which means that you have not adhered to the standard of care, which is the surgical standard of care, which means that we have introduced an infection into the thoracic cavity. And if and when that happens, there has to be a pause in the procedures, and we'll have to do a systematic review to find out where is the source, and that has to be rectified before further procedures are done in that unit. So in summary, rigid thoracoscopy is a different beast. It has got a slightly steeper learning curve. The skill set is quite unique, and it is different to acquire from a flexible bronchoscopy. It expands the scope of interventions possible, and it is a good hack to master in what you would call an IT terms, and it has its own set of idiosyncrasies, and a closer attention to anesthesia and port position can make learning a lot easier. Thank you.
Thank you, Arjun. This was excellent presentation on technique of doing rigid thoracoscopy. One of the best lectures I've ever heard. Congratulations for covering this aspect so beautifully and in so simple way. And your videos were really excellent and very much informative. Thanks once again. So now I think the stage is set for the panel discussion, and we have Dr. Shyam also joining from Kolkata. Hi, Dr. Shyam.
Hi, Dr. Goel. Am I audible?
Yes, yes. So could you please tell us something about yourself?
So so I'll introduce myself. I'm Dr. Shyam Krishnan. So I work as an interventional pulmonologist at CMRI Hospital in Kolkata. I've basically done my post-graduation from GMC Surat, and then my DNB from Fortis Kolkata, and then I learned my interventional training from Dr. Ravi Mehta in Bangalore. And now I work at CMRI. I work with Dr. Rajadhar. I lead the interventional unit over here. I've been passionate about intervention, and Dr. Abhyankar, Dr. Arjun, they've all been I've learned a lot from them, and as you can see, they're like, I hope the audience who are logged in can ask as much as questions and learn from their experience as well. There is silence when Dr. Goel is.
Yeah, I think Dr. Goel is silent. So
Dr. Silent, yeah.
I think he's logged out. So I think let's kickstart the whole idea of.
Yes.
So I joined in.
Dr. Goel has joined in.
He joined in.
So something
Right.
happened.
Yeah.
Not sure how it happened, but anyways. So one thing I can tell you about Dr. Shyam is that he is an excellent interventional pulmonologist, one of the most courageous interventional pulmonologists, and he showed me a case of football size mediastinal cyst, a patient who was not fit for anesthesia, not fit for surgery, and he managed this case beautifully by EBUS bronchoscopy. So heads are off to you, Dr. Shyam Krishnan, and you do a lot of innovative work. And of course,
Thanks a lot.
pulmonology is quite safe with the people and people like you, Arjun, around. So India has come a long way in interventional pulmonology, but you are creating the future and the flag bearers of interventional pulmonology. So with these words,
you.
we are set for the panel discussion, and of course, a lot of information has already been shared. So I would start with Venkar, because he's the most senior and the most experienced medical thoracoscopist in the country. So I would like to know from you, Dr. Nitin, what kind of infrastructure would be required to initiate a rigid thoracoscopy program in an institute for a beginner?
Very frankly, in today's scenario, I think the fact that you can't afford a flexi-rigid will be the best indication. So I think, well, I mean, I'm putting it in a funny way, but at the same time, I think anybody anywhere who has access to laparoscopic instruments, that's one, has some kind of access to operation theater in one way or another, is able to start the setup. So I don't think you require a great depth of infrastructure. You have to imagine that the laparoscopic instruments are little longer and our instruments are little shorter. So you'll need some kind of adjustment in that. And your biopsy forceps have to be little larger cupped and little larger, bigger and larger in size. So if you really see the infrastructure from the point of view of infrastructure, I don't think it's so difficult, because most of the, say, tier 2 cities in this country have a bronchoscopy suite. And even in a bronchoscopy suite, a thoracoscopy, which is diagnostic, pure diagnostic, can be very easily done even in the absence of anesthetist. So the infrastructure requirements are not too many, but one has to know what are we aiming at. If I'm purely doing a diagnostic interventional thoracoscopy, medical thoracoscopy, midazolam, fentanyl, that's my limitation, then rigid or flexi-rigid, it doesn't really matter. What you need is a correct kind of sterile techniques, and the sterile techniques is something which physicians have to learn actively. Very frankly, every single fellow of mine, we have had 37 of them, they had to be initiated into the thoracoscopy suit differently. Bronchoscopy mein they were comfortable because वो mask और gloves डाल के अंदर जाना है, कुछ नहीं करना है. Because every physician is trained differently, every surgeon is trained differently. We have to behave like surgeons, and that is very important. So I think that sterile, surgical, drapes, gown, gloves, all that attitude, mask, everything, the whole thing has to come in place, and that doesn't take much. It only takes the change in the attitude. And very frankly, that is not an infrastructural change, it's an attitudinal change that has to be brought in. If you are getting into a thoracoscopy suit, you behave like as if you are really going to operate a big tumor. It doesn't matter whether you land up doing that, you don't land up doing that, you are going to do mostly biopsies, but that's enough. But or you do a talc powder agent come out, but at the same time the precautions are the same, and therefore that attitudinal change is the biggest infrastructural change I would look forward to.
Thank you, Dr. Nitin, for such nice way of putting this issue. So many times the beginners saying, oh, we don't have the infrastructure, we can't do it, but you can do it with the basic infrastructure which is available in your setup, and just need to be more careful and know especially the aseptic precautions like a surgeon. So you have to, as a pulmonologist, also behave like a surgeon. So that is the key message from you. So now I ask a very basic question to Dr. Swami Pawar from Bombay. Medical thoracoscopy is actually an extension of the chest tube drainage and thoracocentesis, and majority of the time you are able to get a diagnosis by doing a thoracocentesis itself. So what would be your indications for doing medical thoracoscopy?
Conventionally, when you do approach a pleural effusion, most of the time, 60 to 70% times, the pleural fluid analysis will give you the results. It is the undiagnosed, where the diagnosis is not very much clear. It is the time when you will go for a medical thoracoscopy or a thoracoscopic diagnosis, pleural diagnosis. Most of the time when you have a dilemma, whether it is an infective or a malignant pleural effusion, that is the time when you will do it. The other indication for the medical thoracoscopy, especially in a pneumothorax, when you have a recurrent pneumothorax, and when you basically miss out on small blebs and bullae on a conventional CT. medical thoracoscopy can actually identify those things very rightly. Even those patients who have recurrent pneumothorax, they are the people who you should be aiming to do a medical thoracoscopy and provide them a therapeutic advantage of talc powder.
So that's very rightly said. So any undiagnosed extradural pleural effusion, which you're not able to diagnose with routine thoracocentesis, and where there is high probability of having a malignant lesion, where you want to have a larger biopsy pieces for immunohistochemistry and also staging of the lung cancer, then this becomes a very important and in fact the mandatory sort of a procedure to do it. So very well said. And I would now ask Dr. Pratibha, what would be the contraindication when you would not like to do a medical thoracoscopy?
Yeah, the contraindication for the beginners would be any bleeding diathesis you shouldn't do. And more than that, before starting, because taking up the procedure, you must think about the pleural space, if the pleural space is adequate or not, because the rigid setup needs a liberal pleural space. Either we create it by creating a pneumothorax, or we have a moderate effusion at least. If we have a very limited effusion, sometimes we have done the thoracoscopy when patient has just 50 cc or 70 cc, but we have created a pneumothorax. So we see that our lung is collapsed and we have space for our equipment to be accommodated. So for the beginners, the most important contraindication would be absence of a pleural space. So just be very sure, bedside or on-site ultrasound will help you do that. If you have more skillful, then as Dr. Nitin Abhyankar said, we used to use a bottin needle to create a pneumothorax. We use a simple 50 cc syringe, a cannula, and a 3-way to introduce a pneumothorax.
I think we talk about the standard practice. We talk about the simple basic rigid thoracoscopy. So what would be the contraindication in those cases?
Then we must look for any bleeding diathesis. We should not do that. If patient is hemodynamically unstable, we should not do that. If patient is having hypoxia, we should avoid doing that, because patient lying in a lateral decupitous position sometimes changes the hemodynamic, the return to the heart very badly, and there are more chances of complication. So broadly speaking, we have 3 or 4 complications when we should not take up the patient for a rigid thoracoscopy. One is small pleural space, second hemodynamic instability, third hypoxia, and a bleeding dyscrasia or bleeding diathesis is an absolute contraindication.
That's very nicely said, Dr. Pratibha. And one of, I think, important contraindication, a relative contraindication would be very obese patient, where you may not dissect the chest wall enough, and the trocar and cannula may not be
right,
have enough length to reach into the pleural space. So that would be one additional contraindication. So that's very well said. And you would do a procedure in a patient who is able to lie flat or in a position for at least 1 hour without any discomfort. So you want a very stable kind of a patient. It's not an emergency procedure. You have to do it a procedure as an active procedure, and where your patient has to be stable. So
another relative contraindication, Dr. Manoj, would be a patient who has lots of cough. So when you use the trocar or the instrument inside and the patient coughs, the lung expands and you lose the pleural space. And there are more chances of surgical emphysema in such patients.
So cough is a very big problem, especially when you're doing a thoracoscopy, where the complication rate would go up and the procedure itself becomes very, very difficult. So cough management is extremely important while doing a thoracoscope. So they're very well said, Dr. Pratibha. Now I would ask Dr. Shyam Krishnan. So you have got a case where you think you can do a medical thoracoscopy in this patient, but still you would be a little reluctant, and you would ask your thoracic surgeon friend to do it. So who are the cases who you would refer for thoracic surgery? For doing medical.
So one is, So the cases I would usually seek a surgeon's help is basically if, like Dr. Gogia said, if you have extensive fibrosis that you can't delineate the plane, you don't know where the pleura starts and where it's how much it's extending. Those cases I wouldn't touch at all, because you need to find a plane. Arjun does it well because he's an expert. He's almost like a surgeon. But those are the cases I would kind of refrain from, where you have extensive fibrosis. extensive fibrosis in the pleural space where you can't find any gap where you can actually put in a trocar, or you don't find any gap. The second one I would be reluctant to go in would be if I find a thick visceral rind as well. The pleural, the parietal pleural is thickened plus the visceral rind. Those are the cases where the surgeons would do a better job at doing the decortication as well in the same sitting. So any complicated empyemas, stage 3 and beyond, I would happily refer to the surgeon. Fibrothorax, where I can't find adequate space, then CKD patients, empyemas, loculated effusions in CKD patients, they bleed a lot. And I've had trouble, I spent hours controlling the bleed. So they are the ones whom I would happily refer to a surgeon. And the rest, I think, so we can manage. So these are the basic cases which I wouldn't be happy to do.
So,
Yeah,
Dr.
but at
Shah,
the
very
same
well
time,
said.
can I come in for a minute? I mean,
Yes, yes.
Please.
Yes, please.
Shyam, what
Yes.
you said, the last sentence, where you said, somebody with a creatinine which is high and uremic, and the surgeon will very happily refuse in any case. So, in any case, the ball will be back to you.
I think I can say very well said, Dr. Nitin and Dr. Shyam. Anytime that you feel not confident that you'll be able to do the procedure safely and you will not come out with the result, and you're not able to possibly handle the complications should they arise, then these are the cases where you should refer to the surgeon who is much more experienced, has got much more expertise and the facilities to take care of these kinds of patients. So, and one case of, as Dr. Pratibha said, with patient who is coughing a lot, where you are not able to control the cough, possibly these are the cases who would require anesthesia or maybe a single lung ventilation where the anesthetist and the surgeons can come to your rescue. So, Dr. Arjun, you talked about the bleeding tendency and coagulation profile of these patients. We know that is an elective procedure and there is standard guidelines for interrupting the anticoagulation. So what would be your advice if somebody is on antiplatelets and anticoagulants before doing thoracoscopy, and how would you interrupt these anticoagulants and antiplatelets?
We would like with the bronchoscopic procedures. So if the patient is on clopidogrel or any of the newer antiplatelets, then we would stop these things after talking to the person who has started it, whether it can be safely stopped. Now we'd stop it for at least 5 days, 5 to 7 days before you take the patient up the procedure. And if it is going to be a diagnostic procedure, then no ecosprin. If the patient is on, we would continue the ecosprin. And if the patient is on any of anticoagulation per se, then we switch it over to a low molecular weight heparin. If it can be switched over, and then you continue with that, and then probably skip one dose of that and then do the procedure. But again, any of these patients would carry a much higher risk, and the discussion with the patient and the attenders would we need to include the fact that this patient carries a much higher risk than normal for bleed, and the indications and contraindications, the benefit of the procedure, everything has to be discussed in addition to the normal discussion that we carry out with patients when we do a diagnostic procedure. That is something that it has to be discussed and documented, whichever way that is appropriate.
So that's right. In fact, though we don't have the studies, we suggest that if you do a thoracoscopy in patient who are coagulopathy or who are on antiplatelets, there is a high risk of bleeding. But this is an elective procedure, and we should follow the standard guidelines from the British Hematology Society and manage the anticoagulant and antiplatelet therapy in these patients. That's very, very important. We can't afford to have bleeding in a diagnostic procedure and land up in difficult problems. So coming to Dr. Nitin, please. So you have stressed a lot about the use of the ultrasound guidance while doing the procedure, and it is mandatory now. It's a criminal if you do any thoracoscopic or even pleural aspiration without ultrasound guidance. It's actually criminal. So there are two ways we can go about. We can go with the X mark sign, where the patient is shifted to the radiology room. The radiologist marks the X point of the point of entry, and then he comes to the thoracoscopy suite or broncho suite and you do the procedure. Other one is that you have a on-site availability of the ultrasound. So what would be the preference and how would you go about? What do you think should be the right idea to do?
So if you really ask me, I think the best idea for a upcoming pulmonologist is to learn UHU yourself, mark it yourself. Only problem is going to be the licensing and the other issues. They will vary locally. So I think that is going to be a little bit of a problem. But at the same time, the fact that you have used ultrasound guide is good enough. The other way, very frankly, in my center, very frankly, we don't afford to every time, because we are just about 20 meters away. But even at 20 meters away, people are busy doing their routine ultrasonologies, UAG procedures. So what we do is just before the procedure, one of my juniors goes there. He marks the best site for going in, and we also make sure that we mark the diaphragm in the highest position in the sense of expiration related excursions. So once we have done that, we are reasonably safe to go in because our mark is there. Of course, sometimes the mark really comes in a very weird place because the effusions are loculated there, and then you have to manipulate it in such a way that the drain is not going into the back of the patient and he's completely unable to sleep in the night. So that has to be adjusted. But once you take care of that kind of a scenario, most of the times absolutely real-time ultrasonography is, though mandatory, it is not practicable in every center. And we are talking of a country like India. We are talking of secondary, taluka places and jilla places where these kind of things, tertiary care centers have everything and they can afford to do everything by the book and by the rule. But at the same time, it may not be realistic. So I think making sure that you have made an attempt and informed the patient in a correct way that, oh, look, these are the precautions that we have taken. We have had a CT, we have had a ultrasonography, we have had marking of the diaphragm in the best possible position, and then we have gone ahead with the procedure. And we have also made sure that by putting a needle, we have aspirated fluid enough to document that, yes, we are getting into the pleural space, fluid or whatever it is, air, depending on what we are looking at. So I think all these are good enough. I'm not saying they're ideal. The ideal way still will, in the utopian world, will be on-site sonography. Fantastic to have it, but then there are so many great things in the world everybody can't afford or everybody can't achieve. So I think there will be some compromises one way or the other.
That's absolutely right. So ideally, you should have on-site ultrasonography available, but the X-mark thoracoscopy is a good alternative. But please do not do thoracoscopy without the ultrasound guidance in any ways, or in fact, any of the pleural procedure.
Absolutely. So if you ask me what is the standard of care today, I would have to recommend on-site ultrasonography. But there are times when we do it, or rather 80% of the times we get away with, because there are moderate to large size effusions, and why have you become pulmonologists who are experienced? We are better than surgeons in many ways because we have understood things differently. And we have understood that, okay, पहले pleural tapping करते थे तो उस समय marking कहाँ होता था?
So I think we are running short of time, so move on to the next question, Dr. Nitin.
Please.
So this question goes to Dr. Swami. When as a beginner, you want to know how much should be the minimum fluid available to do a thoracoscopy. You can do a thoracoscopy in a patient who doesn't have any effusion. But for a beginner, what would be the minimum amount of fluid that would be required to do a thoracoscopy safely? What is your idea on this?
For the beginner, when you are actually trying to learn the art or you have apprehensions, then it is better to enter the space which has at least moderate pleural effusion, somewhere around 300 to 500 ml, so that the chances of hitting the lungs are much less. But as you rightly said, there are ways to create, even in a effusion lesser than that, you can actually use a pleural needle, introduce a pneumothorax and create it as a hydropneumothorax, create a space in the pleura so that you don't hit the lung. The most important thing is that when you are actually doing the dissection, when you are actually separating the intercostal muscle and you are going to actually penetrate the parietal pleura, that space is very, very important, because if there is some amount of force or some amount of miscalculation or too much of force, then you can end up hitting on the lung, and that can cause a severe injury. It can create a bronchopleural fistula, or it can create an air leak, or it can create excessive bleeding. And when you actually enter the pleural space, your vision will be obscured. So it is very important as a beginner, you should select the cases which are simple. On the ultrasonography, though it is very difficult to understand how much is the adhesions or how much is the loculations, and many times it can mislead you also. But USG is the reliably safe mode which can guide you. So as Nitin sir has said, it is
So as I get from you that in fact you should do an ultrasound and see that there is enough space between the parietal pleura and the visceral pleura, sufficient enough for you to introduce a trocar and cannula. Not actually the amount of fluid. What matters is how much is the distance between the parietal pleura and the visceral pleura, and have enough space for the introduction of the trocar and cannula. Very well said, done. Now, coming to a very tricky condition, Dr. Arjun, we talk a lot about the infection and sepsis, and we generally do not talk about the re-expansional pulmonary edema. In fact, one of the participants asked about re-expansional pulmonary edema, and it is a real problem. The two complications which I fear the most is infection and the re-expansional pulmonary edema. And if you talk to the various thoracoscopy, they'll say, no, we can remove liters and liters of fluid out without any problem, but re-expansional pulmonary edema does occur. It is not reported. We don't report our complications, as a matter of fact. Difficult to diagnose, but at least in my experience, I've got 5 cases of re-expansional pulmonary, when one of them actually died. So if you got a large pleural effusion, say fluid with a cavity with 2 or 3 liters of fluid, maybe 3 liters of fluid, how would you go about, managing these patients for prevention of the re-expansional pulmonary edema, Dr. Arjun?
Very excellent point, Dr. Manoj, and like you rightly said, these are practical issues that you face, and on one hand, you are happy that you got a large effusion as a beginner to say that, okay, I'm not going to injure the lung. And then on the other hand, that there's always a chance that the patient would have a re-expansion pulmonary edema. What we generally tend to do would be that when you have a large effusion, we would probably the day before the procedure, we would try and tap out at least a liter or liter and a half, to try and see whether the patient is tolerating, whether the patient is having an improvement in dyspnea. Sometimes we even tap on 2 consecutive days and try and reduce it to a manageable amount when we are doing the procedure. So the problem is not when you're doing the procedure. When you're doing the procedure, so what happens is, once all the fluid is out, because you need to have most of the fluid out for you to have vision to see what is abnormal to take a biopsy. Especially when you're doing a diagnostic procedure, the patient is only under conscious sedation. The minute most of the fluid comes out, and because of instrumentation, the patient coughs, then there is a significant, there is a sudden expansion of the lung. And the sudden expansion of the lung, with increasing expansion of the lung, the edema occurs and the patient coughs more, and then you lose the space. And when you're about to complete the procedure, or once you have completed the procedure, you have attached the chest drain and connected to underwater seal, all of a sudden this happens. So one is obviously to try and tap out as much fluid as possible in probably 1 or 2 settings before you actually take the patient up for procedure, especially with large pleural effusion. Second would be, we find, over the last 3-4 years, this cough component comes down significantly if you have these patients rather than under just conscious sedation. If these patients are more deeply sedated, the cough reflex sort of comes down, and you're able to have a more measured expansion of the lung. And third thing is, if the patient is not coughing, then you have the chest drain inside, and you feel that the patient, you have drained a lot more fluid than what you would normally drain. Then you can put in the chest drain and then clamp the tube. But this always carries the risk that if the patient starts coughing and you have a large parietal incision and a small skin incision because you have tied it quite tightly, this patient will have the air forced into the subcutaneous plane. Patient may end up with a large subcutaneous emphysema, which can be quite disfiguring to the patient, and can be the patient's attenders can be quite taken aback by the way the patient looks at the end of where the post procedure. So these are certain things that you can do: a much deeper sedation, multiple tab before the procedure, and if the patient is not coughing, then you can try and clamp and reduce it, release the clamp slowly.
Excellent, Dr. Arjun. And this is one of the complications we should really fear and must avoid. That's very, very important, because this could be life-threatening, and would be very painful. So please do not remove liters and liters of fluid in one go. The standard practice, a standard guideline, if you look at, is that do not remove 1.5 liter of fluid if the patient is tolerating. Do not remove more than 1.5 liter of fluid in one go. So that is standard practice we should follow as much as possible, even while doing a thoracoscopic procedure. Now coming to another very important point. What is the typical...
I want to add one thing. I'm sorry to interrupt. I want to add one thing. In case we have around 2 liters of fluid, so after removing 500 or 600 ml, I tell my nurse to keep on keeping a count, because sometimes you forget it. Then I let the patient take 4 to 5 spontaneous breath. So the fluid is replaced by air. So I have learned it with years of this thing, that you in between, if the patient is under sedation, you let him breathe on his own for 5 to 7 breaths and let the air go inside. So the fluid is replaced by the air, and that way we have less incidence of cough and less incidence of re-expansion of the lung.
Very well said, Dr. Pratibha. So when we are aspirating, when we're creating an hemotherapy, we should aspirate the fluid very judicially. We should not just take the fluid and suck the fluid very fast. It must be gradual, suctioning the fluid. At the same time, the air would go inside and, sort of maintain the intrapleural pressure. So that's a very well said point, Dr. Pratibha. Thank you. So I come to Dr. Shyam again. What are the typical pitfalls during the scope insertion? I mean, the dissecting the thoracoscopy, dissecting the thoracic wall during this procedure, what precautions would you take?
So I feel space, you have to delineate the space very well. So for which an ultrasound is very, very important, a bedside ultrasound or a pre-procedure ultrasound. And the other, a very important precaution or a practice which I follow is, once I create a port, I actually sweep my finger around the parietal pleura just to ensure that there are no adhesions. And if there are adhesions, it gets freed. So once I'm happy there is space, I can insert my finger into the hole, and sweep the parietal pleura around, and then I proceed inserting the trocar. And the moment you should never force the trocar. I always try to dissect the pleura and try to get your finger into the parietal pleura and sweep it, and then you insert the trocar. That's my way of doing it safely and avoiding lung lacerations.
So what precaution would you take while dissecting the thoracic cavity? How would you,
So blunt forceps, Dr. Arjun had very nicely demonstrated in his video. Always use the blunt forceps, the angle like he had shown, and open, never close the forceps and then come out. Always insert the forceps, split the muscle fibers or the tissue, and then come out with the forceps open. Never close it back and then pull it, because you might catch a vessel and then pull it out and it might end up in a bleed. If it's a patient like, CKD patients again, the skin incision itself bleeds a lot sometimes. So that time you can always have a monopolo cautery where you can cauterize the bleeding vessels at the edges of the skin of the incision and then go ahead. These are the basic precautions I would.
Excellent. So you would make the incision on top of the lower rib, and
yes,
make only the incision, the skin, and rest of all is a blood dissection by the artery process. So very well said, and this is very important point. You go inside with the closed forceps, but when you come out, then your forceps should be open. The prongs of the forceps should be open when you come out. So that's a very important point that Dr. Krishnan has, just elaborated. Now coming back to Dr. Nithin. So while doing the biopsy, which are the areas you would not like to biopsy? Right. So of course we are talking about the basics of thoracoscopy. So we are not going to biopsy the parietal visceral pleura at this point of time. So we are talking the parietal pleura. Yeah. So what areas would you still like to avoid while biopsying the parietal pleural lesions?
I think the standard of care teaching has been to take a biopsy on the rib, by itself. That means you are not going to go into the intercostal space, and the risk of a intercostal artery getting torn is very less likely. But very frankly, by the time you reach the pleura for a diagnostic pleuroscopy also, the pleura is so very well taken up by the disease. And I've shown a number of videos of that, granulomatous, nodular pleuritis, all kind of pleuritis. I don't think you can really in the true sense identify what you're biopsying. So I think that idea is great. When you are able to see the ribs and the interspaces, you take the biopsy on the rib. You are sure that you are not going to bleed. That's one. Of course, then using the pinch and peel technique is Arjun has beautifully demonstrated that in the videos that he showed. Pinch and peel will increase the yield, so that is not a problem. But I think if you really look at it from a diffused nodular pleuritis kind of a situation, where you take the biopsy, is almost impossible to really delineate between the rib and the intercostal space. And then I think that means the fact that you have so much of pleural inflammation, the fact that you will actually hit an intercostal artery is almost unrealistic. So I think you are safe to take a biopsy from wherever you can and use the best area and use soft hands. I think the soft hands is the best idea to start with, and pinch and peel. That is the best idea.
And one area which I would not like to venture into is the apical pleura, where you got all the
there would be no sense.
Never try to take biopsy from that area. So
first of all, reaching the apical pleura with a rigid fluoroscope is almost nearly impossible. I mean, your scope tip will not reach there, and then having a control over their forceps, and then imagining the vessels. So I think it's a strict no-no. I would rather restrict myself to the 5th to 8th and downwards rather than upwards. And of course, don't biopsy diaphragm unnecessarily unless until you have no other area to biopsy. I mean, if there is a nodule sitting absolutely on the diaphragm, again use soft hands and take it from there, but you don't want to perforate the diaphragm.
Thank you, Dr. Nitin. So Arjun, where do you think the rigid thoracoscopy, has advantage over the flexible flexi-rigid thoracoscopy? So could you please elaborate on that?
Rigid thoracoscopy, is definite advantage. So flexi-rigid, the thing that goes for it, it doesn't intimidate you. It's a easy transition for a pulmonologist to do it. But rigid thoracoscopy, especially, once you start, once you are through the learning curve, and we are talking about India, where you're going to be seeing patients who are going to have loculations, who are going to have septations, and most of the patients with a significant pleural effusion or a pleural related complications are also patients who would not be able to afford the surgeon. One is afford the surgeon, and there is a dearth of thoracic surgeons. Surgeons, who would actually, things are improving in the recent times, but surgeons who passionately do the thoracic work are far and few across the country, and especially if you're talking about surgeons who are going to be doing minimally invasive work, in the sense that you don't have a large incision, and so those are the reasons, and that is the reason as to why you would once you're comfortable with flexi-rigid thoracoscopy, if you're going that way, rigid thoracoscopy is something where you can do a little bit more. You don't have to spend a lot of time that the flexi-rigid would take. There is no risk of damage to the scope. There is always risk of damage to the patient. But in flexi-rigid, the scope is so fragile that other than what it is meant for, in the sense of taking a biopsy and coming out, if you try to do anything more, there's always risk of damage to the scope. So, doing a little bit more for the patient, and as you keep pushing boundaries, you find that it does carry a lot of advantages. But for basic diagnostic procedure, then it depends on whatever you can get your hands on, and it is very well possible that somebody who is very good at doing diagnostic thoracoscopy would say that I would not want to do anything more than a flexi-rigid thoracoscopy, and that is a fair enough call for that person to take. And still you would be able to handle about 75 to 80% of the thoracic cases that come to you for come to a intervention pulmonologist.
Very well said, Dr. Arjun. So possibly when you want to do a therapeutic work and you want to do a biopsy from a flat pleural lesions, where your biopsy force of the flexogen may just slip and may not come out with any tissue. So these are the areas, cases where you would go for rigid thoracoscopy. Otherwise, your flexogen thoracoscopy is good enough. And the diagnostic yield with both of them, both the technique is more than 90%. So anyways, I think Dr. Pratibha has to say something. Dr. Pratibha, please.
No, I think on 2 occasions I have to shift from rigid to flexible because the rib space was so narrow and the rigid scope will not enter. So practically we have to shift from, but otherwise what Arjun says stands good.
So we are not talking about, which scope is superior or inferior.
No,
Actually, we should have both in our armamentarium, and, both are complementary rather than competitive to each other. So very well said. So coming back to Dr. Pratibha, to you, about the sample collection. So what kind of samples you would collect and how would you process them?
We try to take, in case the fluid hasn't been shed, we collect the fluid as well because the shedding of the malignant cells is more in the pleural fluid and whole of the pleura sheds the malignant cells in the fluid. So if the diagnostic tap hasn't been done, which is a rare scenario, but sometimes we do take a second sample of the fluid as well while doing the thoracoscopy. Then we take samples both in saline and as well as formalin. So if we have a clear-cut diagnosis of a malignancy, we have a mass and a fluid, we do not send for TB cultures or microbiological analysis in interest of saving money for the patients. But in case we have a doubt that it could be tubercular as well as malignant, we send the sample for gene expert and AFB culture in saline, and we send the sample for histopathology in formalin. So that's the standard practice which I follow. Means you can add more to it if you send it for other things.
No, it's good enough. I mean,
Yeah.
most of the time we are doing for malignant pathology, infectious pathology. So that is the usual indications. And depending on the preclinical status, you would send your samples accordingly. And
Yeah, I would like to add a point here. I started doing something little different, especially after reading the paper by the CMC colleagues. So they take a biopsy and they imprint on a slide. They smudge the sample and they call it imprint cytology, and they send that, and apparently the sensitivity is very good. So I started using that, and I also patients who can where we don't have financial issues, I always send a sample for frozen section also. So I feel that is one thing we underutilize in our setup, because then I can probably pleurodise the patient in the same setting if it's a malignant effusion. And then also cut down if it's malignancy, if shown in the frozen section, I wouldn't send for the tuberculous set and the infectious pathological analysis. So imprint cytology and frozen section is one thing I wanted to let the audience know.
Absolutely right. And other thing is, if you're suspecting infection, particularly if it's looking like an empyema, you would also set the sample to blood culture bottles also. So that is again very important. So coming to Dr. Swami, what are the post-procedure usual orders you give to your patients?
Post-procedure, you have to treat like your bronchoscopy only. Since you will be giving fentanyl and midazolam, you should keep the patient NBM for at least 2 to 3 hours. You should do a chest X-ray post-procedure to see or check for the placement of your drain. And normally you should give an analgesic like simple paracetamol or diclofenac should be more than sufficient. The patient should be monitored. The SpO2 level should be monitored, especially you can continue the oxygen for probably 2 to 3 hours or till the time the hypoxia settles down, the patient cools down. And you should monitor his vital parameters for next 3 to 4 hours. Absolutely right. So, you can't leave the patient on the table. The patient has to be monitored at least for 2 to 3 hours, depending on his clinical condition. And one person must be actually, monitoring this patient and documented. So that's extremely important. Now,
What about the chest X-rays? When would you order chest X-ray in these patients?
Normally, I order chest X-ray after procedure 3 to 4 hours, and the next day chest X-ray. But it depends. Like if you are planning to remove the chest drain on the same setting, if the lung has expanded, then you remove the remove the drain and do the chest X-ray again, and you can send the patient home also.
So thank you. So Dr. Arjun, can you talk about a little bit of the post-op complications which can occur in these patients? You have done the procedure very safely, but still, you are monitoring them, observing something. And do you have any emergency support system for these patients?
Yeah, so like Dr. Swami said, these patients have to be monitored. So we monitor them for up to 4 hours in our recovery room, and then subsequently they get shifted once we see them or one of our fellows see them. There is a dedicated recovery nurse who monitors all the vital parameters. So that's something. So whether you're using a conscious deep sedation vis-a-vis general anesthesia, the most operative thing, the most common thing is, especially with patients with multiple comorbidities, is delayed recovery from these deep sedation and persistent hypoxemia, which can be there for a few hours. And if you're doing for patients who have comorbidities, a lot of them may have underlying COPD, and these patients, especially if they are not left not monitored, they can end up with carbon dioxide narcosis in the post-procedure patient and post-procedure time. And the other thing, the most common thing, and that is something that we have focused a lot in the last few years, is the analgesia aspect. The previous thing would be, since we have the luxury of having an anesthetist with us, and our anesthetists are very enthusiastic about regional blocks, and that is something that we have gone. So this way we are able to come away from a lot of narcotic like opioids that they're being used for these patients in the post procedure. So that way the patients are able to recover a lot faster, and once they are pain free, then they are able to take deep enough breaths so that the lung expands faster also, and they're able to mobilize. So what happens generally is, in a diagnostic thoracoscopy, 2 hours post procedure, once the patient is completely up, the patient is up and about walking in the recovery room, if the patient does not have any postural symptoms, that is under the guidance of the recovery nurse, and that is something that we have inculcated. So this also helps, especially in patients who are elderly. Only if you mobilize them, otherwise they tend to have urinary retention, and these are other complications that you can see in elderly patients. So good observation in the post procedure time, but that does not mean that the patients are going to be confined to the bed. There has to be a way in which these patients are mobilized fast. If they are mobilized fast, then we find that a lot of these diagnostic chest tubes can come out in 3 to 4 hours. That would mean that the patient is able to sleep well in the night. Even if the patient doesn't want to get discharged the same day for whatever reason, then once the chest tube comes out, the pain comes down significantly, and that improves the post procedure period also.
Very well said, Dr. Arjun, and covered a lot of aspects of post-procedure complication, especially the pain management, and which is the biggest, complaint in these patients. It's a painful procedure, and even after procedure, patient may complain of pain, and which has to be, taken care of very, nicely. That's very important. Now, coming to Dr. Pratibha, when would you remove the chest tube in these patients? You have to unmute, Dr. Pratibha. Please unmute.
Yes, I have unmuted. It depends upon, as Shyam has said, that we are not using on-site histopathology or frozen section. If on the fluoroscopic picture, I'm very sure it is tubercular or something, even then I remove the chest tube the next day when I have got the reports with me. In case it is malignant, and I'm sure on the table and patient has another mass, and that is my preclinical diagnosis, and I do the fluorodesis on table, I'll do a talc podraj. Then it depends upon the drainage output, and I still not remove it after 24 hours. I still wait for the pleural discharge to decrease below 300 ml before I take out the tube. My practice might be slightly outdated, but that's what I practice.
No,
In case the next day the report comes out to be gene expert positive or the granuloma, I take out the tube then and there after 24 hours. So I rarely take out the tube 4 to 6 hours or on the same day of my doing the procedure. I still take minimum 24 hours before I remove the tube. So,
very well said. So if you have got a pre-test possibility of tuberculosis and the lesions look like tuberculosis and the lung has expanded, and if you do a chest X-ray, the lung is expanded and there is no fluid, drain of 4 to 5 hours, one can decide on removing it.
right.
The point is, many times our patients have a lot of pain, complaints which are there. We have a population which is quite pain sensitive. So, we talk a lot about daycare, thoracoscopy, remove the tube, send them home. And with, comorbid conditions it is. So preferably in our setting, it's better, especially for the beginners, better to, keep these patients admitted for at least a day. And if there is no drainage of the fluid in next, within 24 hours, and the lung is fully expanded, you can remove the tube most of the time, unless you are contemplating doing any sort of a talc insufflation and other things. Anyways, so coming to, the end of our discussion, coming to Dr. Nitin, how many procedures to be done per year to maintain a proficiency? I mean, you have covered in your presentation, but this is
it's worth repeating.
Yes.
Because 15 under as a trainee, under supervision of somebody who is experienced, and then at least 10 procedures a year is what is recommended by the ERS or most of the international guidelines. So I think 10 procedures means roughly it comes to at least a procedure a month, and preferably you are going to do it not just 1 year but year after year. So I think it's not something which is only done for a year and you have achieved proficiency forever. So I think that is something which is worth keeping in mind, that I think you keep on doing it forever. And if you keep doing one procedure a month, next year you are usually going to do 2 and then 3 and 4. So I think that experience keeps growing.
Thank you, Dr. Nitin. So I think we have covered most of the part of the basics of thoracoscopy and rigid thoracoscopy in particular. And we have addressed majority of the issues. There are a number of questions in the chat box, which are required for the advanced thoracoscopy procedure. And we are going to have 9 more modules where these points would be discussed. And so we leave it these questions to be answered in those sessions. I thank all the panelists, all the eminent speakers, and the audience who joined in from all over India and across the globe. I thank the IAB and Dr. Amita for organizing this event. And just to summarize the whole session, I can say that the rigid thoracoscopy is now something that we should learn. It's actually an extension of the therapeutic, the basic thoracocentesis and chest tube drainage, and it's very easy to learn. One intervention which you can learn in your interventional career early and practice it and excel in this. This procedure is mainly done in conscious sedation with local anesthesia, and therefore it's also called local anesthetic thoracoscopy, or LAT in short. Basically, it is done, a majority of time, it is done as a diagnostic procedure where your target is the lesion in the parietal pleura, and you would avoid lesions in the visceral pleura until the lesions are too large, and you expect that biopsying this lesion will not lead to the laceration of the lung and subsequent bronchopleural fistula. Can be done in patients who are relatively stable, who do not have undue hypoxia because of other reasons. You must rule out the contraindications. Do the procedure only when you're confident of doing the procedure. And anytime you think that the procedure can lead to complications which you cannot handle, it's always better to ask your surgeons to do that procedure. And having said that, a backup ICU facility and a backup of a thoracic surgeon is a real advantage in doing these procedures. And please be friend with them, because if any complication occurs, they are the people who are going to come to your rescue. It needs some sort of a training. It needs some sort of a mindset change that it has to be done like a surgical procedure, and all aseptic precautions have to be taken. And you should be mindful of the complications which can occur during the procedure, intraoperative and post-operatively. Delayed, occurrence of re-expansional pulmonary edema and other complications is always a possibility. So always keep a check of these patients and follow them very carefully. You can do a daycare thoracoscopy in case you are confident you got the enough backup where should the patient develop his sort of emergency, you are able to provide that kind of emergency support. Otherwise, it's better that you keep this patient depending upon your facility at least for a day. You can choose to do a intervention as you get trained, and this is something that is going to be covered in subsequent lectures. So with this, I would again thank all our eminent speakers and all the audience who have joined in, and thank IFB and Dr. Amita for the support, and also the support staff there, CIPLA, for organizing this event. With this, I say goodbye, and once again, thanks to all from the bottom of my heart. Thank you very much.
Thank
Well
you,
said,
sir.
Dr.
Thank you.
Thank
Thank you, sir.
you.
Thank you. Thank you.
From the team IAB, I would like to heartfelt thank you to Dr. Manoj Goyal for moderating the session. Sir really took it as
You
a
did a
captain of the
wonderful
ship.
job. Absolutely great.
Wonderful job, sir. And thank you to all the panelists and the speakers and all the people who joined in and stayed back so late. So it's a wonderful start for the webinar marathon that we have. And hopefully we'll catch you all in the hands-on session.
Thank you
Yep.
so much.
Thank you, Mehul.
Thank you.
And
Thank you.
thanks the team IAB, Dr. Nene, for taking this wonderful initiative. Excellent initiative.
See you all. Good night.
Good
All.
night.
Good night.
Thank you.